Hey everybody, Jennifer here. I want to do a recap of the systematic approach video. Remember that the systematic approach video talks about three components of the systematic approach: the BLS assessment, the primary assessment, and also the secondary assessment. It actually opens up by mentioning that all of these are performed after getting your initial impression of the patient. And they didn't talk too much about the initial impression. I'd like to talk about that for just a little bit. When we talk about the initial impression of our patient, we want to acknowledge that we are experienced and trained caregivers, that we can identify sick patients from across the room. There's no pretense about that. The American Heart Association acknowledges that, but they're not going to spend a lot of time talking about that, and instead they're going to give us a systematic approach that feels like, wow, I have to add in all these extra steps. But you really don't. If your initial impression from across the room is that your patient is unresponsive, you're actually already doing your BLS assessment. If your initial impression of your patient from across the room is that the patient is not breathing or not breathing normally, you're already doing your BLS assessment. So let's just agree that the initial impression is something that experienced, trained caregivers can get from across the room and move on to the actual steps that the American Heart Association identifies. The BLS assessment starts off by determining whether your patient is breathing and whether or not your patient is conscious. Okay, so if your patient's not breathing, or if the breathing is agonal gasps, don't forget that, agonal gasps, not breathing effectively. If the patient's not breathing or has agonal gasps, ineffective breathing, or if they're unconscious, you need to, first of all, summon help. Now, pre-hospitally for me, that's grabbing the radio and calling for a backup or telling them what specific equipment to bring in on their arrival. For you, it might be pressing the code button on the wall, shouting down the hall, or otherwise using your communication devices that you wear inside the hospital. And then you want to do an official pulse and breathing check. You may be wondering why I haven't breathing, I-N-G. There you go. I'm doing well here. You may wonder why I didn't mention opening the airway. Because again, we're acknowledging that you are experienced caregivers, and so your assessment of the pulse and breathing can be done simultaneously with opening the airway. We don't want to make that a long, laborious process. And while we're at it, let's remember a key point here, that your pulse check and breathing check should take no more than 10 seconds. You want to take between 5 and 10 seconds. So let's see, that's going to be less than or equal to 5 to 10 seconds. Oh, for heaven's sake. Seconds. So don't take more than 5 to 10 seconds to determine whether they are breathing and have a pulse. You've definitely called for help by now. And that's it for the BLS assessment. The BLS assessment is just determining, do you need to do CPR or not? That's all that makes it a BLS assessment. Don't get caught up in wording when you think BLS means something. For the American Heart Association, BLS means CPR. So that's your CPR assessment. So let's move on to the primary assessment. The primary assessment is the one with the big mnemonic to start with, A, B, C, D, E. So that's, of course, airway. You guys know that one. Breathing. You're already well underway doing that. Circulation. That's part of your pulse check, but also maybe distal pulses or blood pressure. D is for disability. And E is for exposing. Okay, so your primary assessment, airway, breathing, circulation, disability, and exposing. Remember, at this moment, if you're doing CPR, you're really not getting much into the primary assessment because you've just gotten CPR underway. But at the earliest time, you want to start completing the primary assessment. Check the airway. Is it open? Make it safe by putting in an airway. Are they breathing at all? Is it effective or ineffective? Are you ventilating them effectively? Circulation. Do they have a pulse? And by the way, are you able to generate a pulse with the CPR that you're doing? D is for disability. You're not going to get a great deal of information if CPR is underway. And expose, you want to definitely bare the chest to do CPR, but you also want to check your patient for other injuries or problems. You want to see if there's a knife sticking out somewhere or a syringe hanging out of their arm. These are a little bit more remote, but we have to remember that. The American Heart Association also acknowledges that the resuscitation team, T-A-N-E-O-U-S-L-Y, this resuscitation team might be performing all of these things simultaneously because it's a team of individuals that are working on the patient, not a single person doing the assessment. But let's say that your patient isn't in cardiac arrest. Let's say that this patient instead is a possible stroke patient. Okay, so you've arrived at your patient's side in the room or on scene, and the call has been for someone who has unilateral arm movement, facial droop, and slurred speech. Well, you're still going to start off with airway. Are they breathing, and is it adequate? Do they need an airway made? Second of all, the breathing, what is the quality of the breathing? Are they breathing deeply enough? Are they oxygenating with that breathing? Checking out circulation, are their pulses equal bilaterally? Do they have a blood pressure? Is their blood pressure good? Are they hypertensive, which is a real thing with stroke? Disability, obviously that's going to play right into the stroke assessment there, of course. And then exposure, make sure that we're not missing anything. So your primary assessment isn't just for CPR. It can be for stroke. It can be for chest pain. The patient has chest pain. Do they have an airway and is it open? Are they breathing and is it adequate? If it's short and shallow, if it's ragged, if it's especially labored, add some oxygen. Do they have a pulse? Are the pulses equal bilaterally? Do they have any disability with this? Don't forget that there are strange situations where patients have both strokes and heart attacks simultaneously. The idea is simply that blood's clotting in their veins, and wherever it lodges, it causes a problem. A stroke can precipitate a heart attack can precipitate a stroke. So please keep those things in mind. And then last but not least, we're going to expose the patient and make sure we see all of the possible causes. Okay, so we've covered a lot under initial impression, and we covered the primary assessment. We also covered the BLS assessment. Let's talk about that secondary assessment, because this is where I think the wheels come off the bus a lot with those acronyms or mnemonic devices. Okay, so the the secondary assessment. So the secondary assessment is where we really pin down the things that are going on with our patients. So for example, AVPU. That's alert, alert to voice, alert to pain, or unconscious. So the AVPU assessment is used to determine how down or decreased your patient is. Hopefully, right now, you and I are all A for alert. We're wide awake, we're interacting with our surroundings, we understand things that are going on. But if we're not alert, maybe we are rousable to voice. Maybe your patient, let's stick with patients. Your patient is rousable to voice. You walk in the room and they aren't looking around and interacting with the world around them. But when you call out their name, they respond to the voice. Sometimes that responsiveness is only moaning, but still, they respond to voice. If they don't respond to voice, we need to determine if they respond to pain. Now, we don't like to inflict pain on our patient, but a little pinch on the underarm can help elicit an understanding. We used to do sternal rubs. Those are not our favorite things to do anymore because, well, they're painful and really it can be excessive. So a little pinch on the top of the hand or in the under of the arm, little pinches, see if they respond to pain. And if they don't respond to pain, we determine that the patient is unconscious. So that's what AVPU is for, just determining that level of consciousness. Next acronym that came up in our secondary assessment is the SAMPLE mnemonic. This is one of my favorites. pre-hospitally, we have been doing this one for years. And I liken it to the in-hospital pain assessment. So in the hospital, you guys have been doing that, scale of 1 to 10. 1 is almost no pain whatsoever. 10 is the worst pain that you've ever had. The little smiley faces and frowny faces. Pre-hospitally, we never did this assessment. We've added it in recent years, but we never did that pre-hospitally. But one thing that we always did was the sample history. And I find in teaching that it's something that's just become mainstream for nursing students or allied health professionals and things. And to be honest, I don't know what the doctors learn about that. So I'm not going to ask. So S is for signs and symptoms. So what's going on with your patient? What are they telling you? What do you see when you look at your patients? A is for allergies. And by the way, in case it's not clear, sample is all about the history. What's the history? It might be the history of the present illness, and it might be the history of their past medical history, but either way. Signs and symptoms, allergies, medications. Assessment of patient medications can tell us so much, and also about medication and compliance taking history. P is for past medical history. Oh no, I'm running out of room. L is for last oral intake, and I'm just going to put last PO because I think we all know what that means. Last oral intake, and then E is for events leading up to this. So just to say it, when we talk about events, remember that that's not the time of onset, although that can be a component of it. Events is what was going on when this started. So let's say that we are seeing a patient. We'll kind of go through the ones that we did last time. So we saw a patient who was in cardiac arrest with CPR underway. Well, when we have enough rescuers and we decide to evaluate our sample history on the patient, we're going to ask the family members or the staff on the floor, what was going on with the patient before this occurred? What signs were they displaying? What did they complain of before they went into cardiac arrest? Allergies, not necessarily important unless they've just taken a medication or they have a history of an allergic reaction and may have contacted that allergen. Medications tells us a lot. If they're on blood thinners, if they're on beta blockers, calcium channel blockers, and of course, if they're taking anything recreational or extracurricular. Past medical history can help us a lot with what's going on with our patient. We want to make sure that we understand how they came to be in our care before this CPR event occurred. With CPR, last oral intake is also maybe a little less important, except to say if they just ate a big meal, intubation might be higher up on our interest list. And then events. Before they went into cardiac arrest, did they have a headache? Did they have chest pain? Were they involved in a motor vehicle accident? How about that stroke patient? You can imagine that a patient complaining of headache and has an appearance of droopy on one side of their face and they can't raise an arm, they have slurred speech. Well, those are our signs and symptoms. Are they allergic to anything? Always important, especially if they had contact with it. What medications do they take? If they're on antihypertensives, if they're on blood thinners, also plays a factor into helping confirm the idea of stroke. Past medical history of stroke and many other things. Last oral intake, always important in case we have to manage their airway. And events leading up to it can also tell us. Don't forget, if their past medical history is that they're diabetic, then that's going to be key in ruling in or out a stroke. Okay, let's get to the last acronym or mnemonic that came up. The H's and T's. The H's and T's are too big of a topic to cover right now in our recap of the systematic approach video, but there's another video that covers H's and T's in a little bit more depth and helps give some explanation, so please be sure to reference over to that. Ultimately, we're talking about the systematic approach to patient assessment. The systematic approach will help you assess, treat, and ultimately manage. There's more to treatment than just treatment. There's management of your patients. Hope this recap was of help to you.